joining. We just need a few more minutes. So just to note, the meeting's being recorded. Just make you aware of that. My name is Cecile Town. I am the Deputy Program Manager for the Oregon Immunization Program, and I'll be facilitating today's meeting. We have a great agenda ahead, but before we launch into that, I wanted to do some introductions because we have a new interim program manager, and we also have a new immunization medical director. And this would be the first time that we've been able to introduce them both on this call. So I'm going to, before I let them launch into their introductions, I would also like to invite anybody who is on IPAT when they are done to jump on camera and introduce yourself so they have a sense of who is on this team. And if that's not something you're comfortable doing, please just put your introduction into the chat so that they can catch up on that as we proceed. So with that, I'm going to start with Amanda Faulkner. And Amanda, have you hand it over to Howard? How does that sound?
Good afternoon. I'm Amanda Faulkner. I use she, her pronouns, and I have...
Can everybody hear you? Can everybody hear Amanda? I can't hear her.
I could hear
I can
her.
hear.
I hear her.
Yeah, I can hear her.
Okay, then I'll deal with my sound. Amanda, please proceed.
All right. Well, as Cecile said, I am in the current interim position for the immunization section manager here at the Public Health Division, and I've been here for just a little over, I think, 6 or 7 weeks. I've actually worked at OHA for over 7 years now, and most recently was the manager of the preparedness, surge, and epidemiology team in acute and communicable disease prevention. So immunization is near and dear to my heart. I worked in vaccine preventable bacterial disease at CDC before I came to OHA, and I've had a long friendship with some folks in this program. So I'm really, really happy to be here. And I will pass it over to Howard.
Thanks, Amanda. Great to meet everyone. My name is Howard. I am the new medical director for immunizations and communicable disease, preventive medicine physician, and an anthropologist by training, and have really enjoyed being here since starting. So thanks. Back to you, Cecile.
And I can't see the agenda, but could you tell us what's up next? It sounds like Cecile might be having some difficulty joining us.
Yeah, she can see us, but she can't hear anyone apparently.
Oh, okay.
Next up will be Dean with the West Coast Health Alliance update.
Hi, Dean. Would you go ahead and get started?
Hey everyone, Dean Seidlinger, he, him, his pronouns. I have the privilege of being our health officer and state epidemiologist. Much to the chagrin of my Oregon Immunization Program colleagues, I'm going to go off script a little bit. I'm here to give a West Coast Health Alliance update, which I will, but to do that, I need to put a little federal context into it. And then I'm just going to touch on legislation for a moment because I'm going to leave before the legislative update. So hopefully I won't stir the pot too much. But as you all know, we are still facing a lot of uncertainty on the federal level with evidence-based vaccine recommendations coming out of ACIP and CDC. So in response to that, this past summer, the governors of initially Washington, Oregon, and California formed a group that became known as the West Coast Health Alliance. Within a day, the governor of Hawaii joined. And really our task was to make evidence-based public health prevention recommendations with a focus on immunizations to start. This was at the time where we had uncertainty in fall flu vaccination recommendations, had no recommendations or approvals for fall COVID formulations, and uncertainty about RSV immunization products and what would happen. So we have focused primarily on immunizations and working together to provide evidence-based recommendations for vaccines. We cannot replicate the process of the advisory committee on immunization practices, nor do we want to. But what we said is, okay, as for state health departments, what can we do? We can look to other groups that have compiled information, especially as we went into fall respiratory viral season. We still had great CDC prepared data and presentations that staff had been working on for the Advisory Committee on Immunization Practices, work groups that wasn't necessarily brought forward into the meetings themselves. And then we have some amazing professional organizations like the American Academy of Pediatrics, the American College of Obstetricians and Gynecologists that make recommendations for their patient populations and also kind of show the work on who's impacted the efficacy of vaccines and safety of vaccines, with other professional organizations signing on to those and making recommendations. So one of our first big projects was to make immunization recommendations for the fall. We came together as the 4 states, had some consensus recommendations. They look surprisingly like the previous fall's recommendations, with the major changes being around COVID, moving from a universal 6 months and over recommendation to one that followed the data on who's most impacted, universally recommending a updated COVID vaccine for those under 6 months or under 2 years, 65 and older, and anyone in between with underlying conditions, whether that be environmental conditions such as where they live or work, or health conditions such as immunocompromise or other chronic medical conditions that put them at higher risk, that we recommend they receive a vaccine, but that anyone who wanted a vaccine to protect their child should have access to that at no cost. Otherwise, with the update of RSV products and the new influenza vaccine preparation for the fall, we kind of mirrored the previous falls. As changes started to happen, primarily around the childhood vaccine schedule and moving several vaccines from universal recommendations to shared clinical decision making, we stood by the AAP, the American Academy of Pediatrics recommendations, that children should have access to these vaccines universally, and that there should not be risk-based kind of recommendations. I will say that does create some confusion to the general public, but even to our providers, is what does the shared clinical decision-making mean? And by following the West Coast Health Alliance recommendations, are we going against the ACIP recommendations? And in my mind, we're not. Shared clinical decision-making isn't a process where we just kind of approach the patient or the patient's parents and say, Mr. Jones, Mrs. Jones, what are your thoughts about vaccines for your 1-year-old today? It's a process where we have a discussion about benefits versus risks of vaccines with the patient or the parents in front of us, and through informed consent, which we do for all vaccines, recommend those vaccines, which are then given in whatever setting we're in. I will say, that doesn't preclude us as providers from saying, here are the benefits of a vaccine and here are the potential risks. They would, in our mind, maybe point to a universal recommendation. So that's what we're still doing. We can start with those recommendations based on the evidence of what we're recommending. Different organizations may require documentation a little differently of how they did shared clinical decision making, but it really doesn't change the process in this age of increasing vaccine skepticism, where all of us who give vaccines are having these conversations regularly about risk versus vaccines in a much more kind of in-depth manner, in a longer manner than maybe we had 15 or 20 years ago. And that's maybe not a bad thing. But it is a bad thing when we're having to combat mis and disinformation that exists very widely on the internet, and some of which is coming out of the mouths of members of the Advisory Committee on Immunization Practices. We haven't really had to do that in the past. So we're going to continue to review information as it comes out from ACIP and CDC, try to pre-bunk information if we need to, when we know something may be coming out, and then respond to information that comes out. But as much as possible, we're going to align with professional organizations that are making recommendations based on the evidence and not based on kind of dogma or opinion, which seems to be some of our federal recommendations now, and then work with our fellow agencies within each state to try and support universal access at no cost share to those vaccines where possible in our states. We are watching legislation moving through the courts, a case filed by the American Academy of Pediatrics against our HHS colleagues to stop future ACIP meetings because of the way that the ACIP is configured now, and to roll back the most recent changes to the childhood vaccine schedule that they made. A decision on whether or not to delay future ACIP meetings and to roll back those recommendations is delayed a little bit from what we expected. Arguments have been made in court, but due to the Children's Defense Fund asking to join that lawsuit, which was denied, I think the recommendation is slowed down a little bit. In that context, the ACIP meeting, which was scheduled, I guess, for next week, was delayed until towards the end of the month, and we're waiting to see if that's going to happen. West Coast Health Alliance Immunization Work Group, which is subject matter experts from the health departments in each of the 4 states, will be meeting ahead of that meeting and after that meeting. And then the state health officials in each state, so one from each state, where their designee will be meeting after that meeting to approve a statement or any changes in our recommendations that we need to make, or to reaffirm our recommendations after that meeting happens. With that said, we'll continue to watch vaccine recommendations, other preventive services recommendations should we need to, and respond accordingly. And this is where there's a little bit of overlap with some of the legislative update you'll probably hear about later on in the meeting, but I just want to touch briefly on SB 1598. This was a bill, the primary author was Senator Lisa Reynolds, a pediatrician from here in Portland, but that Public Health Division, Oregon Health Authority, and the governor's office had a tremendous amount of input into. This is a bill that essentially does 3 things that are of interest to you as vaccine providers across the state. It allows broader standing authority for myself as the health officer in Oregon, or my designee, to issue standing orders around therapeutics and preventive kind of medicine. So vaccines, antibiotics, other medications to respond to health issues. That doesn't mean that I will routinely be issuing standing orders, but it's a tool we have to respond to future changes, whether that's abrupt changes in federal recommendations that may potentially disrupt access to vaccines at pharmacies, or an acute urgent situation where across the state or in a geographic area we're recommending certain treatments or post-exposure prophylaxis like immunizations in response, or post-exposure like immunizations in response to an outbreak, that we can perhaps do more quickly than some of our other processes. So it's kind of an additional tool we have. In addition, it allows us similar authority to make recommendations that vaccines be covered at no cost share, which we can currently do at the state level for participants in the Oregon Health Plan. But we don't have that same authority to make recommendations for commercial insurers that are overseen by our partners at the DCBS. So this allows coverage at no cost share for recommended vaccines under regulated private insurers, as well as Oregon Health Plan. These can be above the federal recommendations, which ACA, the Affordable Care Act, refers to, and allows us to continue to follow evidence-based schedules, both in the private market and the public market. And then the third thing that's not really as relevant to vaccines, because we are recommending our own vaccine schedule, but it moves up a date at the that our state laws look to offer preventive services at no cost share to folks covered by the private insurance market, as well as Oregon Health Plan, up to June of 2025 from a date several years ago. And that just allows us to backstop and maintain those services should there be some changes made that aren't following the evidence. So that's a quick down and dirty of that. Hopefully you won't see any changes in the day-to-day things. You're not going to see a lot of standing orders, but it's a tool that we have. And just to be abundantly clear, a standing order is essentially a statewide prescription. It does not give me the authority to compel any provider to do anything, nor does it give me any authority to compel any patient to get any vaccine or therapeutic. But it is just the name we use for a process to facilitate access to vaccines and therapeutics in other settings. So there, I went off script and over time, but I'm going to pause there and see if you want me to take any questions. If not, I'm going to have to hop off in a little bit, but if there are written questions or other questions that people can't answer after I leave, I will get you answers in person, in writing. Cecile.
Yes. So do we have questions for Dean today? Right. And if Anne, please help me if there's people raising their hand and I'm not able to see it.
And I apologize for not asking ahead of time to go a little off script, but you guys are used to me. So.
And please don't worry about the time. We actually meant to give you more time on the agenda, so ignore that number. That does not apply to you. Let's see here.
No hands or questions, but
yeah, thank you for the summary and the updates. Thank you. Lots of moving pieces are the comments. Thank you for the update. And Dean, we really appreciate you for joining us. We know you're on the road. And
yeah. And hopefully Stacy isn't like, oh my God, he said something totally different than I was going to say. And if I did, I apologize, Stacy. Because she's doing the legislative update later.
Yeah. Okay, great. Well, seeing no questions, thank you very much. And feel free to stay with us as long as you're able today.
Thanks. And I just want to say thank you, everyone, for your continued work in this area. It's never boring in the work of immunizations, but the last year and the coming years promise to be even less boring than they have in the past. So I appreciate all the partnerships and work people are doing for us to maintain access to vaccines and promote vaccines that are safe and effective and are doing a lot to keep people in Oregon healthy, regardless of what may come out of the federal government. So thank you.
Thank you. So next up, we have an ACIP update, and that will be from Amanda Timmons.
Good afternoon. Sorry, see if my camera works. We're all updating software and hardware right now, and I know that was Cecile's problem. I have issues with it myself. So glad to see everything's working. Wasn't quite sure what to share with folks regarding the ACIP right now. As Dean mentioned, they're expected to be meeting on the 18th and 19th of this month. We haven't seen an agenda yet, so we don't know what they're going to be discussing, but I did find today that the meeting has been published in the Federal Register, which is one of the steps that has to happen before the committee can actually meet. So that does give some indication that they are intending to meet in a couple of weeks. And we will be paying close attention to what they have to say. I was looking back at the agendas from last December, which was the last time they met. They only published an agenda about 2 weeks before that meeting, and they were changing the agenda right up until the day of the meeting. So it's very possible that we won't have a good sense of what they plan to discuss until we get quite a bit closer to the meeting. That being said, comments, the public comment period is open. So if anyone wants to go to the Federal Register website, there's a link on the CDC's ACIP page. You can provide comments or you can sign up to provide testimony during the public testimony section. I would love to give an indication of what I think that they're going to be discussing, but I honestly don't know at this point. Yeah, could be just about anything. So I think I am, Janet was asking if I could put that link in the chat for public comment. I can as soon as I'm done speaking. I'm having a little trouble multitasking, but I will do that before we leave this meeting. Okay, and then do people have questions, thoughts, comments, concerns they want to share? Not hearing any, not seeing any. Well, if it's all the same, then I'm going to move on to my second topic, which is new rules around the yellow fever immunization program. And before I share my screen so you can see what I'm discussing, I want to talk a little bit about the process for creating administrative rules. In Oregon, we have a multi-step process anytime an agency wants to promulgate rules, which includes getting a group together of people who will be impacted by the rule to comment on the proposed changes. That's called a rules advisory committee. We don't actually have a rules advisory committee for yellow fever specifically. So we are looking to get an exception from that requirement. There's a couple of reasons for that, but one of them is the RAC is supposed to be made up of people who will be impacted by the change, and we don't know who those people are, which will make a little more sense when I go into the change that we're wanting to make. So we're trying to get the message out broadly that we are planning to do this change so that if people have concerns or comments, they are able to comment on that and get that information to us before we actually do the rule change. So part of that is by bringing this change to IPAT, we're bringing it to folks that might have interest in or be impacted by the change. It's only one of the strategies that we're using, but I appreciate your forbearance while we go through this. Okay, so I'm going to go ahead and share my screen. Right, and hopefully you can see that. This is the statement of need and fiscal impact for a rule change. This is one of the first documents that gets filed. It gets printed in the Oregon Blue Book, which isn't actually a book anymore. But it has some specific things in it. This change is actually relatively minor, but it does shift cost from the immunization program onto individual providers. So we're trying to be very careful about making sure that we get that information out. The federal regulation delegates issuing uniform yellow fever stamps to the states. In the past, Oregon has paid for those stamps. They've ordered them on behalf of the providers and mailed them out. That, in addition to the cost of the stamp itself, it also cost us administrative fees in terms of having staff to track those purchases, to get them mailed out and sent. And we don't have the staff or budget really anymore to be doing it. So we want to shift that cost onto the providers themselves. Once they submit an application for a yellow fever stamp, then once it is approved, we would send them information on what the specifications have to be for the stamp, and they would be able to order it from any supplier that they wish. I also need to go through with you the actual rule changes. So I'll do that here in a second. This really only applies to providers who are applying to become yellow fever immunization centers, so travel clinics, and it only applies to those who are going to be doing that from here on out, not the clinics that are already certified yellow fever sites. So let me switch over to the rules themselves. And we're actually changing only two rules. The first one is 0430. We are changing the definition of a yellow stamp, of a uniform stamp that shows that it's to validate the International Certificate of Immunization or Prophylaxis. And then we're changing 0440, prescriber participation. And essentially, the biggest change is that we're deleting subsection 4 that says the authority shall order and mail the stamp, and instead adding a section that says obtain and use a stamp to validate international certificates of vaccination that meets authority specifications for the stamp as notified in or as identified in the approval notification. So I'm going to go ahead and stop sharing. That is just about it. It's a pretty simplistic change. What the plan is from here is to request an exception from the RAC process to make sure that we send this information out in our provider updates and also make sure it's posted on our website. And my intent is also to notify current yellow fever stamp holders of the change so that we're most likely able to get it to the folks who would be most likely to be impacted. Any questions on that?
Cindy wants to know what the anticipated cost to the provider might be.
It's about $20. The stamp itself is about $20. You can actually find them probably for a little less. And of course, it doesn't cover any administrative burden on the behalf of the provider. Any other questions, thoughts, concerns?
And Amanda, the administrative burden on behalf of the provider, that was actually something that was already in place. That's not changing. It's
only that they would have to order the stamp. So that someone on their staff would have to find and order the stamp, which was something we would have done in the past.
Right. But the administration costs, et cetera, would be
the actual vaccine administration costs are typically reimbursed by insurance or by the person receiving them. So that has not changed. As folks probably know, most travel medicine is paid for out of pocket by patients. So that isn't changing.
Is it reasonably easy to find someone who can make a stamp to the required specifications, whatever they are?
It is actually. I went and looked up online because so many things are done online these days. And there are multiple providers who can do it online, or you can get one from Staples or from Office Depot. They also make custom stamps.
Yeah,
Great,
there's
thanks.
not a lot of requirements. It just has to fit inside a certain box on the certificate. So there's a size parameter, and that's pretty much the main, I don't know, requirement.
Requirement, right. Yeah. And because people only are required to ever get one yellow fever vaccine in their lifetime, if it's a little bigger than that and it doesn't quite fit in the box, it's not going to be a huge issue because people don't get multiple of this vaccine. And the yellow fever vaccination card is specific to yellow fever vaccine. Any other questions? And if not, I'll pass it back to Cecile.
All right. Thank you, Amanda.
Thanks.
And group, we always take questions in the chat after the fact, and we can go over them later on in the agenda, as we will do with the introductions as well. So next up, we have Stacy Matthews, who's doing the legislative overview. Or I'm sorry, I think it's a legislative update.
Thanks, Cecile. So legislative session was relatively quiet for immunization topics this year. Oregon alternates every other year between a short and a long session, and this was a short session, so that's sort of nice. There were 2 bills that we tracked and will now be going to the governor for signature. So I'm going to start with the one that Dean did not talk about. That is House Bill 4149. So this bill adds language to state statute that is very similar to existing language in a federal law called the McKinney-Vento Act. And this law directs schools to immediately enroll students who are identified as homeless even if they're missing otherwise required documentation, such as a birth certificate or an immunization record. And it also directs the school district liaison for homeless students to provide assistance with meeting immunization requirements for the student. So, because this federal act already exists, these provisions are already followed by schools, and we don't anticipate any changes from the passage of this bill. It simply preserves the language in state statute should the federal law ever change in the future. And there was a good amount of testimony in support of this bill. There was very little opposition, and it passed easily in both chambers. And just so you know, we already have longstanding language in our school immunization administrative rules that supports these procedures for students who are considered homeless and outlines some of the assistance that schools must provide to these students, including school staff requesting records from previous schools, helping contact a previous medical provider for the family, checking alert records, and connecting families with immunization services. And a year or two ago, we actually worked with the Department of Education's McKinney-Vento team to create an info sheet that can help families and schools know the rights and responsibilities around immunizations and students who are considered homeless. All right. The second bill is the one that Dean talked about, Senate Bill 1598. He did a great job covering sort of the parts of that bill and what it involves. So I'm going to skip to what is the immunization program's role in implementing this bill? Well, we might be asked to draft the standing order language if an order applies to a vaccine. So the immunization program currently writes model immunization protocols and would likely use a similar process for drafting a standing order if one were issued. There was a large amount of testimony, both for and against this bill. There were 750 pieces of written testimony submitted. A little over a third were in support of this bill, and a little under 2/3 were against this bill. And a lot of the testimony against it stemmed from the misconception that a standing order would be a mandate or a requirement somehow that people get a vaccine, which of course it's not. Dean did a great job of clarifying that that is not what a standing order is. It is not a mandate. It simply gives permission. And the bill actually explicitly states a standing order issued under this section may not require a person to receive, use, or administer a drug or device. So it's specifically stated in the bill. Despite that, there was a lot of confusion about it and some organized testimony against it. So that's sort of a summary of the two bills that we tracked. They are now heading to the governor's office. I believe that it's likely that both of those bills will be signed. And even though it was a slow session for us, whenever there is a bill concerning immunizations, it definitely has the potential to draw a lot of attention. And happy to answer any questions. And one last thing, I wanted to give a thank you to Amanda Timmons, who is really our legislative lead, who did a lot of work tracking these bills throughout the session and doing bill analyses on these.
Are there any questions or concerns for Stacy? Okay, thank you, Stacy, for that update. And I always appreciate that anything that you update us on, you make it so joyful, and you always have your engaging smile and pleasant manner. I would want you to be the person to give me bad news someday. All right, so next up on our agenda, everyone, we are going to welcome Dr. Melissa Sutton, who will be giving us an update on measles as well as measles wastewater surveillance.
Hi, everyone. Thanks, Cecile. Like Cecile and Amanda, I am testing out some new hardware today. So we're going to cross our fingers that things go well. If I have any audio issues, please let me know. I might need to turn my camera off. Um, so, yeah, I'm here today with a measles briefing. I am Melissa Sutton. I'm the medical director of respiratory viral pathogens over in the acute and communicable disease prevention section. I use the she, her pronouns. I'm going to take us back in time to 1962 here in the United States, looking at measles cases. So, just prior to the measles vaccine being licensed in 1963. And you can see that back then, we had something like 400 to 500,000 measles cases reported each year. Following the vaccine licensure in 1963, we saw measles drop off precipitously. And then we sort of entered into a fairly regular cycle of increases in measles every 5 to 7 years until 1989, when the second dose of measles vaccine was recommended. And then 10 years later, we entered elimination. And so, taking us into the current day, sort of the elimination phase, 2000 and beyond, you can see that for about, I don't know, 14, 15 years, we really had very little measles activity. So all of these cases were either importations or cases linked to importations. We did not have measles really circulating throughout our communities. We have seen measles activity increase pretty dramatically in the last probably 10-ish years. And you can see that last year was a real turning point for the United States. We had almost 2,300 measles cases reported. And this year, unfortunately, we are 2 months into the year and we have had more than 1,100 cases reported. So we are definitely on track to far surpass our 2025 numbers. So we've really entered a new era in terms of measles transmission. And of course, in 2026, the United States elimination status will be reconsidered. I think many of us feel pretty certain it will be lost, but that will ultimately be decided by the WHO. So we know that vaccination rates determine measles risk. And this is a map from the CDC website. You can see that our states that are outlined in red have the lowest vaccination rates. Our pink states are sort of in the middle, and our blue states are doing a little bit better than others. These don't perfectly correlate to current measles activity, but it is really important to understand local vaccine rates because what it really speaks to is the potential for measles activity and the potential for measles outbreaks. So here in Oregon, we have very high levels of vaccine exemptions. There was an MMWR that was published in 2023, 2024, which is why I'm referencing that year in particular, that showed that Oregon had the fourth highest percent of kindergartner medical and non-medical exemptions at 8.9%. So fourth only after Idaho, Alaska, and Utah. And if you looked at the national estimate, the national average, it was 3.3%. So we truly are an outlier. Now, that year, we had 91.2% of kindergartners who had received 2 doses of MMR. Nationally, the rate was a little higher at 92.7%, and our herd immunity threshold is really upwards of 92%, between 92 and 94%. These population-based vaccine rates don't really tell the full story because I don't know about you, but for me, when I hear 91.2%, I think, gosh, that's pretty good. It's not great. It's not where we want it to be, but it sounds really high. And I think what we need to really consider is that it's an average, and we have unimmunized communities throughout the state of Oregon. So while overall we are at 91%, there could be a school down the road with a 25% vaccination rate. And those individuals are, of course, at dramatically increased risk for a measles outbreak. Unfortunately, MMR coverage rates among kindergartners in Oregon have been falling fairly steadily over the last 15 years. You can see that for 2024, 2025, the rate had reached 90.5%, which, is not where we need it to be. And again, is a population-based average and very much reflects these pockets of unimmunized communities. So our measles activity since 1992 has been pretty minimal. You can see 1991 was a big year for us here, and a shout out to Dr. Cieslak, who made this graphic. Thank you, Paul. We had 93 cases back then, but since then, we've really just had a handful of cases each year, and some years, no cases at all, up until 2019, when we had an outbreak with 28 cases, and then 2024, when we had an outbreak with 31. So this year, we are currently at 6 cases, and we have met the criteria for a measles outbreak. Of those 6 cases, 5 are unvaccinated and 1 has an unknown vaccine status. We do update our OHA measles website every Friday with revised case counts, which include vaccination status, hospitalizations, and deaths. Fortunately, none of those 6 cases have required hospitalization and none have died. 6 cases doesn't sound like a lot, but we know that it's really only the tip of the iceberg. We know that we're only identifying a small proportion of the true cases that are out there. So, in addition to our case surveillance for measles, we have relatively newly measles wastewater surveillance. This is something that we launched back in the fall in October. It's an extension of our current wastewater surveillance program with Oregon State University. And in any given week, we have somewhere between 32 and 40 communities who take part in our surveillance. They participate voluntarily, so you will definitely see on our dashboards that there are weeks that a community might not send in a sample. We're definitely very grateful for their participation. And we have learned a lot from the measles wastewater surveillance. It's really given us unique insight into the sense we had that there was a lot more measles than we knew about. So we currently submit all of our wastewater data to the CDC National Wastewater Surveillance System. And it is displayed on their dashboard as detection, no detection. And it's worth pointing out that the NWSS dashboard uses a very high threshold for detection. And I won't go into the science of that. But they do this very purposefully. It's because they want the detections to mean that there is likely a case that you will detect there in the community. So the higher the threshold, the more likely you are to find an associated case. And I think that makes sense. At the same time, using an approach with such a high threshold can actually mischaracterize risk. And I'll show you what I'm referring to. So this is the NWSS measles dashboard. This is, I think, from last Friday's update. And you can see the green dots are no detections of measles, and the purple dot, the lone purple dot, is a detection. Now, we know that in the United States, we have several active outbreaks of measles. And yet, when we look at this map, we see a lone dot in Utah. I hope I'm getting my geography right. And so I think that this can give the impression that measles is uncommon, and it is uncommon, but that the risk is rare. And I don't think that that's quite true. So for our other respiratory viruses, for COVID-19, for flu, and for RSV, we display our wastewater data as viral concentration levels. The advantage of this approach is that it allows for trending, it allows for categorization, and I think it better characterizes presence in the community, which is a proxy really for risk. So we launched a measles viral concentration dashboard a couple of weeks ago, at the same time that we announced our measles outbreak, to align with the NWSS dashboard. We do show our viral concentrations at the county level rather than the community level. And we currently categorize them as very low, low, moderate, and high based on data from a 2024 retrospective study that we did testing the wastewater around the outbreak area in Oregon. So it's really the only data we have to go on. You know, these categories might be updated over time. Yeah, so here's what we found, and I'm going to show a series of snapshots from the dashboard. We felt really strongly that we needed to release the data in a different way because it was telling such a powerful story, and we wanted the people in Oregon to see the same story that we were seeing. So here you can see a screenshot from the first week of the surveillance. And the counties in white are counties that had no detected measles. And then the counties in gray are counties that had no data submitted for that week or that 2-week period. Now, if we move forward into November, you can see we have more counties submitting data, which is good. Many counties with no detectable virus. And then we have 2 counties with very low levels of measles virus. And then as we move into December, you can see we've jumped from 2 to 5 counties with very low levels of measles virus. Moving into January, you can see even more counties with very low levels, and 2 counties actually with low levels. Moving into February, sort of more of that, a little bit more expansion. And then actually in our most recent week, we saw a little less activity. So I think that these data paint a really powerful picture that measles is moving through our communities. We can't tell you how many cases these levels translate to, but I think it's important to know that measles is out there. It can alert clinicians to the risk in their communities. It can also alert families to that risk so that they can make more informed decisions about their vaccination status. Our key messages for healthcare partners have been that measles should be considered in any patient with clinically compatible symptoms, especially if they're unvaccinated, they have an exposure to measles, or they've traveled to an area with a current measles outbreak. Unfortunately, that includes Oregon now. We are also asking that clinicians consider local epidemiology when making vaccine recommendations. The first dose of MMR vaccine can be given as early as 6 months of age. Now, when it's given before 12 months of age, it's considered a 0 dose, and that infant does later have to receive 2 additional doses. But I think that there are families for whom they would be interested in that. And then the second dose of MMR can be given as early as 28 days after the first dose, as long as the child is 1 year of age or older. Again, I think that there are important conversations that providers need to be having with their patients. Our key messages for the public are that measles is very contagious and can cause severe disease, that anyone who's not protected is at risk. That if you or your family are not currently protected, now is a great time to reconsider vaccination. And then also some harm reduction messaging that if you have symptoms of measles, to protect others, please call ahead before you seek health care, if at all possible. Please stay away from others to protect them from disease. And then we're highlighting warning signs because we know that there can be a reluctance within certain communities to seek care when they have measles. So, really pointing out that measles can be dangerous and that when you see someone's not doing well, it's incredibly important to see a healthcare provider. I'm going to stop there and I am happy to take your questions. Thanks so much for your attention. Paul C., I see your hand up.
Yeah, hi. Thank you very much. Can you give me some idea of how well your wastewater findings are correlating with actual cases that have been identified in Oregon?
Yeah, not well at all. Um, Now, in the current day. So our findings did correlate really well when we went to the 2024 outbreak area and we tested around it. But our current cases are not correlating particularly well or really even at all with what we're finding in wastewater. And we think that's because we don't know what we don't know. We know that we're only finding a very small proportion of cases, but what proportion, we really have no idea. Around the holidays, we weren't surprised to see the increase in measles activity with all of the traveling and, of course, with all of the indoor shared air. But yeah, they're not correlating.
So I gather that you're stratifying your virologic data, whereas the feds have sort of just a set threshold that's maybe higher. Where is that threshold in relation to your strata?
So with the assay, you have a limit of detection. So a level at which you can say confidently that you are seeing wild type measles in wastewater. So the federal threshold is that level plus four or more partitions on the DCPR or DPCR platform. We do not use a number of partitions threshold. We simply report the viral concentration detected.
Okay, thanks.
Yeah, Rex has a great question about how the cases we found have been identified. And I guess one thing I should say, Paul, is that while the individual cases or the wastewater findings are not necessarily correlating with where the cases are being found, the overall increase in wastewater is very much correlating with the overall increase in case activity. So we have found the cases through people seeking healthcare and providers being really aware of what measles looks like. I think because of how much we're talking about measles now, uh, suspect measles cases are immediately reportable in Oregon. So we get called about most of these cases in real time, and we're able to provide clinical assessments. And then if it really truly sounds like measles, we try to get that specimen sent over to the Oregon State Public Health Lab for rapid testing. What percent of cases need to seek care? Yeah, I think that's a tough thing to answer. So last year, about 11% of US cases required hospitalization. So if you use that as a threshold, um, that's sort of having to seek care if you're so sick that you require hospitalization. But a greater number than that experience complications of measles and certainly should seek care. And care seeking is so complex. So, the people who have sought care and been detected, it's really a combination of, parental concern, um, probably a known exposure, although they didn't report that to us. And then sometimes illness severity. Yeah, I see Caitlin's question about, do we know anything about how the viral load changes over the course of the disease? Yeah, we really have a very poor understanding of shedding. So no, and it's a really difficult thing to actually study because you sort of have to, hold people in a controlled environment and collect all of their urine and stool and test it, and it's very difficult to do. And we saw with COVID some early attempts to do that, and it didn't work very well. Um, so what we know is that the wild type measles is real. It's in the wastewater. It's not vaccine-derived virus. So we know measles is passing through our communities, but we really don't know much beyond that. The last thing I will add is that we know that other jurisdictions are finding the same thing that we're finding. And I do think over time there will be more of a movement towards displaying viral concentration data. I have spoken to CDC leadership about us doing this, and they're definitely supportive. It's not something they plan on pivoting to in the near future, although I can definitely see them moving in that way uh, if we lose our elimination status later this year.
Are you reading the other questions as they pop up? Oh, actually, that one from Deb Wemsey is that she needs to step off. I thought that was a new question.
I think we're all questioned out. Thank you, everyone.
Yes. Thank you, Dr. Sutton, for joining us and spending this time with us today. Very useful and very helpful. So if we don't have any other questions for Dr. Sutton, or if we do, but also have questions for other presenters, we are at the point of our meeting where we're at a roundtable. So this roundtable is time for us to talk about possible topics for future meetings, any items that are of concern to all of you as our membership that you just want to bring up in this forum where we can talk about it.
I would really like to know how we're doing in terms of vaccinating people. I mean, can we tell from alert whether our vaccination rates have fallen significantly since the new revised ACIP has come along? How much is that affecting Oregon rates?
Hi, Paul. This is Rex. Just coming off mute, took a moment. I'm Rex Larson. I'm the Surveillance and Quality Manager with the Immunization Program, and it's really a great question about the changes in the ACIP childhood immunization schedule, how they might be impacting rates in Oregon. We did run some preliminary data looking at just doses administered over time by week since the ACIP changes, and we have not seen a decline associated with the ACIP changes. If anything, there could be just a small bump in immunization rates, it's really preliminary data. And I think just to note that rates were already in decline and have declined year over year, just a small amount each year, but pretty consistently since 2021. So I don't know that we should be feeling optimistic about that small bump, but at least it doesn't look like the ACIP had any sort of immediate or precipitous impact on rates in Oregon. We'll know more when we publish our 2025 end of year rates in a few weeks, about a month or so for 2-year-olds. I think those will be the ones that will show the earliest impact. But I think we're going to see a pretty similar trend to what we've seen over the past few years, which is a small decline each year, probably. But it's a great question. Thank you so much.
Thanks.
There's an update in the chat from Stacy Matthews. We are in the process of collecting school immunization data currently and can update IPAT at the next meeting. That would be in June. Great. All right, this is not to stop the flow of questions and discussion, but I did want to circle back because I had some technical difficulties at the beginning of the meeting to invite members of IPAT to you can come on camera or not, but to introduce themselves to the room so that some of our newer members can meet other members. And if you are not comfortable doing so, please put your introduction into the chat. But I would love to put the onus on. Oh yeah, there we go. Janet's starting. Thanks, Janet. Go ahead.
Hi, Janet Patton. I'm a family physician. I represent the Oregon Academy of Family Physicians.
Thank you.
Hi, I'm Paul Cieslak. I'm a retired public health physician and practicing now as adult infectious disease physician.
Great to have you here, Paul.
Hi, I'm Ann King. I'm the state director for Oregon for Comagine Health, and we work with clinics and hospitals and nursing homes on immunizations, among a lot of other things as well.
Thank you.
Hi, I'm Lisa Chambliss. I'm a communicable disease nurse with Lane County Public Health, representing local health departments, and I use she, her pronouns.
Thank you, Lisa.
Hi. Oh, sorry.
Go ahead.
I'm Tara Gardner-Brown. I'm a family nurse practitioner. I'm the director of health services at Portland State University and representing the universities across the state. Thank you.
Hi, I'm Molly Sachs. I'm the coordinator for Immunize Oregon, the statewide immunization coalition.
Hi, I'm Jen Gibbons. I'm a naturopathic doctor here in the Portland area, and I represent the naturopathic community.
Thank you.
Hello, my name is Clarice Charging, and I'm the immunization coordinator for the Northwest Portland Area Indian Health Board.
Hi, Clarice. Lovely to have you. Christy Polanco, thank you for putting your introduction into the chat. There's a request from Janet Patton to please have IPAT members leave their cameras on for this section so we can see one another. She says she misses seeing all of you. Right. Let's see. Are there any other members who would like to offer an introduction? Since we have a little bit of time, we don't normally do this in IPAT, but I would like to invite the OIP staff who have joined us for today to introduce themselves as well. There's sometimes we have our crew on because they're subject matter experts and can help aid the discussion. So it might be helpful to the members to know who they are. So we've heard from Rex, we've heard from Stacy and Amanda.
I can go, Cecile.
Thanks, Jenny.
Hi, everybody. I am Jenny McKibben. I use she, her pronouns. I am an IPAT member and an OIP staffer. I am the Alert IIS director, and I manage our team in the program that does all of our data systems work. So I'm happy to be here and always happy to see your faces that I haven't seen in a long time. Thanks.
All right. Anyone else?
I can go next. My name is Caitlin Miranda, and I am the new data quality coordinator for the Alert IIS. And yeah, I'm happy to be here.
Caitlin's one of the newer members of our program, and it's my understanding we had a lot to keep you busy in terms of data quality work when you came on board. Is that correct?
Oh yeah, having so much fun. And I think I might recognize some folks from my previous role at the lab. So if my name looks familiar, we've probably met. Hi, Lisa. Yes, hello.
Hello, I'm Marie Martinez. I'm with the Oregon Immunization Plan as the Vaccine for Children coordinator.
Thanks, Marie.
Hi, everyone. My name is Angela Fisher. I am the data systems coordinator. I manage the system work for our OIP staff.
Thanks, Angela.
Hi, everybody. I'm Beth Borderstrass. I'm on Rex's team. I'm an epidemiologist and do a lot of data analysis with Alert.
Thank you, Beth.
Hello, I'm Paul Fapel. I am the adult immunization coordinator at OIP. I work with our vaccine access program providers, doing enrollments and support.
Hello, I'm Brianna Weston. I am the Alert IAS trainer.
Thank you, Paul. Brianna?
And I'm Vivian Larson, immunization epidemiologist. Sorry, I'm off camera today.
Thanks for joining us, Vivian. I'm not looking at the participant list, so I'm not sure if you're on and you haven't gone yet. I'm just going to put a call out there. Who's next? Okay. So the wonderful team that coordinates IPAT and gets everything rolling for these quarterly meetings, Stacy, Ann, and Amanda, just want to check in with you and make sure there is nothing else that we need to cover before we give people time back for today.
I have nothing. This is Ann. So.
Thank you, Ann.
This is Amanda. I don't have anything either, although I would encourage the members to jot down a note for us if you have any suggestions for upcoming meeting items.
Perfect. Janet, I see your hand raised.
Yes, I'm part of the vaccine finance group. And it's a mess, and we've lost staff at OHA, and the legislature did not approve the ongoing funds requested. And so we are trying to sort out how we can sustain vaccine purchases for Oregon, which we now are setting up a meeting with the OHA director and trying to explain this very complicated process. So I'm volunteering myself to give a short presentation, which will force me to get that together so that we can explain to legislators and others who need to know about what the problems Oregon is facing as far as vaccine purchase and distribution. Thanks.
Wonderful.
Janet, this is Amanda. I was going to say that would be awesome. And I'm wondering if you might also like to present to our office hours group at some point, which is made up of folks who don't necessarily attend IPAT, but are providers in the community.
Sure. Let me cut my teeth on IPAT and
not a problem.
Feedback.
I will ask again. Thank you.
All right, thanks.
Yeah, and and Janet's offer also does extend to others. If there's work that you're doing that you want to share with this group, by all means, do let us know. We can schedule you for one of the quarterly meetings without a problem. We would appreciate you being able to use this forum to share information that's of interest to immunization policy. Also, there's a reminder for this group that we have an upcoming Oregon Partner Update Live. And on this session, we will, Dr. Paul Offit will be on. Can somebody please tell me the date of that session?
March 18th.
March 18th.
March 18th. Okay, great. And I believe we might be able to put the link right here. There it is. There's the registration link. Thank you, Stacy. And for those of you who may have been on our listserv for a long time, you might have noticed that within the past 6 or so months, we have a new format. There's still listserv updates, but we have a new communications team lead and a new communications manager, that is, and she has created those as partner updates and kind of given them like a newsletter style appearance and look and feel. And then we have brought in, instead of doing these public provider orientations that we used to do, we will every once in a while do a partner update live, which is more of a gathering of folks together, of course, virtually, to hear different presentations. And so that's what that is. And so we do invite you to register and attend. Wasn't there, Amanda, going to be some kind of ACIP event rescheduled for March 18th?
Yes, that is actually when ACIP is scheduled to meet.
That's what I thought. Okay, because I did look on the Federal Register comment period, and it was really asking for comments for April, and I wasn't sure if I was understanding the March date or not.
Yeah, that's what's on their website, on ACIP's website, but as we've heard others people say that is subject to change. They haven't been as predictable as in the past.
So get the comments in as soon as possible.
Absolutely.
All right, wonderful. All right, any other topics that are out there waiting to be added to the next IPAT agenda? And we did have some folks let us know that they weren't able to make it today because they didn't have it on their calendar. And just wanted to let you know that I talked to Ann about it, and she doesn't usually send out a calendar hold to membership for this meeting because not everybody can parse that information. They can't do the ICS invitation on their calendar. And that has been an issue in the past. So we can talk as a group here about how to, sort of get some advance notice going so that people can mark their calendars a little bit more in advance for that meeting, and which will be in June. I believe it's the first Thursday in June.
Yeah, June 4.
Okay, so maybe from 12 to 2, everybody could individually put a hold on their calendar for now while we work that out, just to make sure that you don't miss the next one.
I mean, I'll say that, I'd be interested in a recap of the viral respiratory season, with an eye on, how have our vaccination rates been against COVID, RSV, flu. And in addition, I put in the chat earlier that there was, I was surprised to see CDC recommending polio vaccine for American travelers, including to some countries in Europe. I know this isn't really Oregon specific, but it'd be kind of, I'd be very interested to hear about the global polio situation. We were on the verge of eradicating it not too long ago, and that seems to be out the window.
Yeah, I agree, being pretty surprised at seeing that news yesterday. I remember, gosh, it was back in 2005, and I went over to Ghana and worked for 3 months on the polio eradication efforts. And we had been really close to eradicating it just before that. And there was some political activity that it started to pop back out. But, we've just come so far from that at this point, and it's discouraging to see. So a global immunization update, is that what you said, Paul? Just to make sure I'm getting it right.
Well, Oregon respiratory viral season recap, and then I was more specifically interested in polio. I don't know, but don't have to try to cover everything. Oh.
Sure. Okay. All right. Other ideas? If not, our next meeting is June 4th from 12 to 2. Thank you so much for joining us for the March IPAT, and this meeting is concluded.
Thanks. Good seeing y'all.
You as well, Paul. Thanks.
Thank you.